I'd like to start by just introducing our leaders today. They are Deirdre and Catherine. Catherine is from Cavan in Ireland. I don't know why I had to look that up. I know we've just talked about this. But she's been in Norfolk for 17 years and doing this current role for 5. And she previously worked in other mental health services as a carer's lead. Deirdre comes to us from County Corkfire, Wales, and has worked since qualification in Norfolk and in London. She said her recent stint, which is a decade long, has been in Norfolk, and she's worked as a psychologist for the whole time. And today they're going to talk to us particularly about the service that they've developed, which was part of the Wave 1 funding that Jay was talking about, and the specific interventions around mental health and supporting people. Just a housekeeping note before we start, please remember to put yourselves on mute if you're not speaking, and take yourselves off mute if you are, to avoid the cringeworthy "you're on mute" comment. And we are going to have a presentation of around 20 minutes, and then there will be time for Q&A after.
Thank you, Sarah. Okay, so I'm going to start the presentation and just say that what our project, which was the Wave 1 funding from NHS England, or supported by that, was to try and work with carers to increase long-term safety in adults who have chronic suicide risk.
Okay, so the aims of the session today is to share the approach that we've developed in Norfolk and Suffolk Mental Health Foundation Trust, which involves carers more closely when dealing with and managing suicide risk in chronically suicidal service users. This is a short presentation, and we've allowed some time at the end for questions and answers to gain some critical feedback about your ideas, and to also gain some new ideas as we take the project forward, and to hear and understand whether or not you're aware of any similar initiatives happening for you. I'm going to pass back to Deirdre.
Okay, so the reason we chose to focus on carer engagement was that there's lots of evidence suggesting that it may prevent suicides if we can engage carers more effectively. So the national evidence comes mainly from Lewis Appleby's team in Manchester, who's spoken this morning, but they looked at what health professionals would do differently when they'd lost a service user to suicide, and nearly 17% of them said that they would have involved family or carers more closely. We also had our own local evidence. So if those working in the health service will know that when we lose a service user to suicide, we have we produce a serious incident report, it's called, but it's actually a kind of fact-finding exercise about what's happened and what we could do differently. It's so we can learn lessons from that death. So we have 2 local audits that we looked at. The first one suggested that it was from the period 2012 to 2016. It looked at all the service users whose lives were lost to suicide over that period, and it showed that in 10% of those cases, or nearly 10% of those cases, a carer or family member had got in contact with us suggesting that the risk was increasing, or to raise the alarm in effect, and there hadn't been a corresponding step up in the care that we provided. And we've done a local review of our lives lost to suicide, and so I'm working with a bit of an echo here, but we've done our local review of last year's lives lost to suicide, and again we found that in 15% of those, it's actually in 9 patient deaths, the person who conducted the review suggested that families or carers should have been more closely involved as one of the lessons to learn. So that's kind of 9 avoidable deaths that we could avoid, possibly by increasing our carer engagement. Okay.
So additional reasons to effectively involve carers. We know that carers so often bear the emotional brunt of responding to the risk of a suicidal loved one, and they deserve our support, and we feel that we need to provide that support. They are very much often left managing the risk alone, not having access to services out of hours, over weekends, on holidays, and in particular when the service user has been discharged from an acute mental health ward setting. And we know that the risk can increase in these at this time in that 72-hour period post-discharge, and in some cases up to 6 months afterwards. We also know that the COVID pandemic has put additional pressure on so many carers. Access to support services for our service users and for our carers has reduced as a consequence of this. And as we've heard earlier this morning, you know, lockdowns have placed enormous pressure on service users, their carers, families, children, young people, and of course NHS staff as well. Carers are very often the only person in our service users support bubble. And we also understand that carers may at times be in conflict with mental health services about approaches taken. And this conflict may negatively impact on the service user. So our Stepping Back Safely project aims to increase collaborative working with our service users, carers and staff, because we know that when carers feel part of the process, it enables them to build resilience, it helps them feel supported, and it also helps them feel that we are all working in it together. And we hope that by doing this work that we can reduce some of that conflict.
Yeah. So we started off small in Great Yarmouth and Waveney, which is one of our locality areas. It has about 3,900 patients in that area, community and acute, in our mental health trust. And we developed our project in that site. But we've now got, having had some Wave 1 funding, we've now got funding from within our trust to roll it out across the trust for the next 2 years. So we chose the Great Yarmouth and Waveney area partly because if anyone knows it, it's got high levels of social deprivation. We knew that there were high levels of suicide there, and there was a strained relationship between the trust and service user and carer advocacy groups. But actually that also meant that there were staff, service users and carers who were highly committed to service improvement. So we chose to site our project there originally and develop it from that setting.
So the background of how we got there, so we held some focus groups with service users and carers to understand what they needed to effectively manage risk together.
So out of those focus groups, and we ran focus groups with staff as well. We discovered that safety plans were not routinely being shared by service users with their carers or by staff with carers, and carers weren't routinely being involved. And carers asked us for more support around what they termed stepping back safely. So the language that mental health services were using around risk management and positive risk taking was felt to be quite offensive, and actually carers said we need to change the language and the thinking about that and think about how we can step back safely. So that gave us the name for our project.
We also held focus groups with staff who told us that they wanted training in how they could engage with carers, and who were very highly distressed or needed additional support, and also those people who were alienated from services. So from our focus groups, we developed the interventions within 3 interventions, which make up the Stepping Back Safely project. We've used the triangle of care and recovery approach models to risk as the underlying principles for our project. The triangle of care is a therapeutic relationship between the patient, staff members and the carer that promotes safety, supports communication and sustains well-being. And I'm going to hand back over to Deirdre to talk about the recovery approaches.
Okay, so the recovery approach to risk focuses on the idea of a life worth living. So many people, when they're suicidal, can't see a point of carrying on, and actually, that one of the recovery approaches is to give people a life worth living and to work with the service user to increase their connection. That's connection to other people and to their communities, their hope, to bolster their identity, to give their lives meaning, and to empower them. So we wanted to embody a recovery approach to risk, which is slightly at odds with the traditional kind of medical approach to risk. And we were also aware that some of our service users become very reliant on services to manage their risk for them at times when they're feeling risky. And risk-averse practices do obviously reduce risk in the short term. If we admit someone to hospital, or we put them on observations, or we restrict their access to means, we can reduce the risk in the short term. But this can increase the risk in the long term, and it also sometimes opposes the recovery process and the development of a life worth living. Because while service users their whole life can sometimes become based around their interactions with the mental health services, rather than based around the things that are going to give them their lives value and meaning. So we wanted to situate our interventions within that recovery approach. We've put some more material here about the dimensions of recovery that they're called CHIME: connectedness, hope, identity, meaning in life, and empowerment. But these are the kind of principles that were guiding our interventions as well. Okay. And then we worked with one of our peer tutors who has herself got lived experience of being in what she calls the need to be looked after trap. And it's a sort of circular thing where when the service user, at the top of this circle, when they enter into suicidal states of mind, it creates anxiety about their ability to cope in the whole system, and that's completely understandable. But if we move on and believe that the service user can't cope, and we take control away from the service user at that point, we're reinforcing that belief. So we may all become, and that includes staff as well, staff, carer and service user, more and more risk averse and more controlling of the risk. And if we go around to the consequences box, that in the long term undermines the service user's sense of their own control and agency, and also sometimes reduces the trust of the carer and the staff member in the service user's capacity to cope. So we wanted to get away from this kind of vicious circle to a more virtual circle where the service users that we were developing the approach for, as I mentioned, are people who are chronically suicidal. So they may have long-term mental health issues. They may intermittently become suicidal in response to triggers, but we wanted to give the service user hope and confidence in their ability to cope and help them develop some skills to coping. So if we start at the feelings box at the top, when the service user next feels suicidal, we'd like there to be less anxiety about their ability to cope. And then that can produce a different set of thoughts, which is, although this is a really difficult moment, it might even be a really risky moment, the service user can get through it and knows what to do in terms of using support and skills. And then the behaviour at that point would be to consult the safety plan, which we develop, and to soothe and validate and make a plan how to get through this difficult moment. And the consequences of that long term is that the whole system builds resilience and the service user can carry on working on their recovery goals or their life worth living goals. So it's trying to kind of turn the vicious circle into a virtuous circle, but to do that safely, with a really detailed and personalised understanding of what the risk is and what triggers it. So we developed 3 interventions. I'm going to describe our systemic safety planning intervention. Catherine's going to describe the carer workshop, and then I think we're both going to describe the staff training. So our safety planning intervention we developed as a 4-session intervention where the carer, the service user, the member of staff and a therapist and a carer's lead all get together to look at developing a highly personalised safety plan for that service user. So within this safety plan, we focus on developing a common understanding of triggers and vulnerability factors, and we collect the knowledge that everyone has about that. So often a carer would have a different knowledge of what the triggers were and what the vulnerability factors were than the service user, but we collect all the information that everyone has around that. We have an open conversation about the balance of short and long-term risks of a risk-averse approach. So we would just look at the pros and cons of an approach that maybe be quite restrictive, so might involve hospitalisation or taking away the means, or approach that would be less restrictive, and we talk about that openly. We consider the obstacles in terms of moving forward to a more recovery-oriented risk plan. And crucially, I think the most important thing that the intervention does is it rebuilds the relationships in that triangle of care if they've been eroded, and it increases collaboration and it increases trust. So after the intervention, I think carers feel much more ready to pick up the phone, and they feel they're going to be much more listened to because their experience has already been acknowledged within the safety plan and their contribution to that. In the sessions, we also we have a workbook that runs alongside the sessions that the service user and the carer can look at, and it coaches people to develop different skills. So how to distract themselves when they're feeling risky, how to soothe themselves when they're feeling risky, and how to use the support that's available for them. And by the end of 4 sessions, it'll hopefully be quite a detailed and complete safety plan that everyone has some hope and confidence in. Observed effects of doing this, we were found that the more personalised safety plan gave us more information and increased understanding of the whole system of what leads to the risky episode, much more information than had previously been available on our electronic patient record. So we had such more detail about what was difficult for that person and what they were struggling with. Generally leaded to increased skills use and self-management by the service user, and increased confidence in this by everyone, and increased prompting by the system to help the service user access those things that they know to be helpful. It changed the way help and support was being used in such a way that long-term risk was not increased. So we didn't want service users becoming reliant on a particular thing solely to manage, a particular source of support to manage the risk, because that is also risky, because when that particular source of support isn't around, they haven't got anything to fall back on. So this gave them some fallback skills as well for when support wasn't available. And I know that Lewis Appleby's team, they've identified that risky times for carers for service users aren't just when people are discharged from hospital and things. It's often when there's been a change in care. So when they've had like a change in care coordinator, or a usual source of support is not available to them. So it's actually trying to reduce the service user's dependency on just one source of support as a way of managing risk. It has a shared understanding of and support for the recovery approach. And often one of the very moving things that gets to be discussed in those sessions is that people have lost an awful lot in their lives. There's been loss events like loss of relationships, loss of jobs, but actually people have stopped doing the things that give their life meaning and value. So it's a chance to kind of think about how we can support that. How can they get those things back in their life that they need? And it signposts the service user and carer towards other interventions as well. So we have a fantastic recovery college in NSFT. We've got an awful lot of stuff available for service user and carer within that. But it might be signposting towards a particular clinical intervention if we identify a problem, say someone's really struggling with hearing voices, for example, or there may be some clinical intervention from that, or it often can be signposting towards third sector community organisations and resources. So getting the service user to develop their life in such a way that it gives it meaning and value long term, and that also develops people's support networks. Okay. These are the categories of things we've got on our safety plan. We have actually got a handout with our safety plan on it, and I think that was going to be circulated or added into the resources available. But, you know, we focus on the traditional things like triggers and early warning signs, how to reduce impulsivity. We have a list of people, including support organisations, that can be telephoned. We focus on self-soothing. We get people to write cheerleading statements to themselves so that they can maintain hope and encouragement in a difficult moment, or things that other people have said to them that helps them maintain hope and encouragement. How people can support me if I'm thinking about suicide. So actually getting a clearer idea of what they need from other people. How others can respond helpfully to me when I'm in this state of mind, making my environment or situation safer. So we get people to focus on actually, if they are feeling extremely risky, how can they make the environment safer just for that period when they're feeling in that high risk state. What people's strengths and resources are, and remind them to keep engaging with that. Activities they can do to distract themselves, including connecting with other people. And then we have a bit at the end where we think about what the next steps are as well. But the safety plan itself doesn't look like this. It's a bit more user friendly. It's 2 sides of A4. It can be folded up and put in a phone case. It can be photographed and put on a phone. And it does seem like we haven't yet had a situation where we can't reach a kind of common agreement between everybody in the room about what might be helpful, or what the kind of critical factors are that make someone feel risky. Okay, Catherine.
Okay, so the carers workshop was developed out of the focus groups, and carers told us that they could not stand the term positive risk taking. So they came up with the name. So the name has come from them. They said that they needed help to step back safely, which is why we've called the project that. There's a 1-day workshop for carers, which we are in the process of developing now to go online, so as we can get going. And you know, it explores the impact of service users' risk on carers, but also on families, and it also acknowledges that this impact. And we listen and validate what people are telling us. The carers that attend can develop a personal plan which can reduce their emotional reactivity to situations of risk. And it encourages carers to increase their emotional resilience by reconnecting with the things that give their lives meaning and value, so that their life and their identity is not wholly wrapped up in their loved one's mental health problems. And we also look at supporting styles, the supporting styles that carers may have adopted in relation to their loved ones, and we look at the pros and cons of this, and we try and get participants to think about how they might want to shift or nudge their supporting style. So I'm going to hand back to Deirdre about the staff training and maybe come in on that as well.
Okay, so we started off with what the staff had requested from their focus groups, which was they felt they really needed help dealing with carers in those high risk kind of situations where a service user was expressing lots of risk, and actually how to manage that, and also how to work alongside all the distress in the system. So we put in a generic training for our staff, which was very well received around that. I think I mentioned that we just started in one clinical area, which was Great Yarmouth and Waveney, but we've now got some money from within the trust to roll this out across the whole trust. So we are now going to be doing, we're going to be working with our carers leads across the trust to incorporate some generic staff training in there. But we are going to be doing some specific training for people who want to run the safety planning intervention, and specific training for people who want to run the carers workshop. So it's going to move into more of a train the trainers kind of format from this point forward. Okay,
and I was just going to say that we're also looking for some our PSWs. We have peer support workers within our teams, and we also have a big cohort of staff who are themselves carers outside of their clinical and professional roles. So we've got a lot of interest from those members of staff who want to be involved in supporting not just the staff training, but also the other two elements as well, the carers workshop and the systemic safety planning.
Okay. So we've got funding for 2 years for 2 days a week of our time to try and roll this out across the trust. We're trying to embed it and adapt in different clinical areas. We know we'll have to have some adaptation. So the way obviously community youth services operate and the situation of young people is different from those in our adult services. And again, in acute inpatient services. And we're developing a train the trainers approach because we want to make involving the carers in safety planning and supporting the carers with risk part of our standard clinical offer within services, because obviously our own audit suggests that wasn't happening routinely. So we do really genuinely welcome critical feedback and also any ideas from what you're doing in your areas of work. We're happy to share anything we have, you know, the workbooks, the safety plans, the training content, and we're happy to make connections kind of, you know, nationally and see what else is going on, see whether we can learn together basically. But that's the end of the presentation, and we're just interested in hearing
your feedback.
Would it be helpful if I started by putting some of the thoughts and comments and questions in the chat to you?
Yeah, that would be great. Thank you, Sarah.
And Sangeeta has raised her hand, which is cool. So Sangeeta, I will come to you in a moment. So some of the questions, I feel like I'm not going to do these chronologically for those who wrote questions. One of the questions that was asked, I think you may have slightly already answered, was who runs the workshops? What are their skills and qualifications? You know, what's the thing behind that? And I feel like you did sort of answer that at the end. But was there anything else you wanted to share on that?
So the safety planning intervention is run usually with a psychologist and a therapist, by a psychologist and a therapist, but in the room you ideally would have someone who the carer feels is an advocate for them. So when I ran it with Catherine was that person. And you'd also have the service user, the carer and their lead care professional, because you're kind of trying to strengthen that triangle really and make sure that those three people, who are the critical three people, are all on the same page with everything, and that trust is there, you know, so that when there is a moment of crisis, people can, manage that moment. In terms of the carer training, we did involve people with lived experience of caring. Catherine has her own lived experience of caring, but we involved a carer locally in putting together some of the materials for that. She didn't want to front the workshop, but we are now moving forward to a stage where the workshop for carers will be delivered by carers leads and ideally also by one of our carers locally. We've just started to have some carer peer support workers and things. So we'd like that to have the lived experience in the room, because we feel that will be much more powerful for carers to be supported by someone who's actually been through that journey themselves with respect to risk. So that's the way we're going forward with that. And the training the trainers will be done by me and Catherine. So we'll be kind of doing less of the interventions and hopefully empowering people to do those interventions, and then moving back to kind of provide the training to support those interventions is the idea.
And there'll be general support for people, support sessions for people that are doing that as well.
Thank you. I wanted to, in case people need to go, because I'm mindful of the time, ask this next. And whoever doesn't want to answer it, could you just write the same in the chat box for me? So people would like to know where they can find out more information about your work. And particularly somebody asked whether or not you could share a template of the safety plan.
Yeah, we had already done this, but I think the NSPA weren't sure whether they could. They had a thing to save it. So just email us. We've got we've put our emails, I think, on the presentation, or if not, we're pretty easy to find in NSF team. We're happy to share anything we've developed, and we'd be delighted to get stuff back that's similar as well, so that we can look at what else is happening. Because I'm sure there's other things happening all over the country, but in kind of isolated pockets that we could learn from. So that would be great to hear from anyone who's doing something similar or involved in something similar.
There are some great comments in the chat, and I think there was one line that said, "Please contact Hampshire."
Yes, I saw that.
I mean, obviously
Thank
you
you.
can see the chat as well, and it will stay around afterwards, so I can share the chat with you for those ideas and feedback. So one of the sort of things that's come up, particularly during the beginning of your presentation, is your thoughts on more complicated cases and how to ensure that carer engagement is always at its best. And obviously, inevitably, that doesn't always happen. So, you know, what happens if something doesn't go to plan or goes wrong when you're caring for a particular service user?
I think we have to be really open about the fact it's gone wrong. That's the starting point. As this has gone wrong, it's time to think again. You know, so obviously these plans aren't watertight. You know, and I think we just have to be really. That's the starting point. I think everyone is shocked when there's a risk event. You know, obviously even more shocked if we lose, you know, a service user loses their life to suicide. But when, say, we're working with someone and there's a near miss or there's something of that nature that happens, I think everyone is shocked. And actually, the sooner that the triangle regroups and rethinks, the better in terms of long-term outcome. And I think it's really important to be really open at that point about what's going on, and actually to hear out everybody's opinion and see whether we can come to consensus again, you know, rather than when the triangle blows apart, the whole thing becomes unstable. So that's what we find, is that, you know, if a service user becomes alienated, or a carer becomes alienated, or a member of staff withdraws, that makes the situation more risky for everybody. So it's trying to keep everyone talking to each other.
And as part of the training team in the trust, we're also delivering safety planning training to all members of staff as mandatory training at this time. So that's we're telling people about what we're doing, and we're encouraging them to come to us, you know, and be involved in what we're doing in all the different service lines. And what we also do in our trust is we have a care awareness package of training for staff. We have 6 carer leads within each of our different care groups. So, you know, we are really starting to try and move things forward in regards to that, to be very aware and open with people as well.
I'm really mindful of the time, and we've got 2 hands up, so I'm just going to, if you could very briefly answer, if you're able to answer this one. How do you look at the care and mental health of those around the person who is the service user, the person who needs help? Do you look at the impact it has on them?
I would say yes, in regards to what our carer leads do, and you know, we offer carers assessments within our trust, and we do always try and ensure that we're asking that question: who else is involved, who are the family, who are the young people, making sure that we're trying to get them support as well as the main supporter in the family. It's not always possible all of the time, but you know, we are really trying to move forward and ensure that we are keeping this as business as usual within the trust. Deirdre, I don't know if you want to say anything else.
Yeah, I suppose there is a route via, we have in Suffolk, in our trust, they do the carers assessments, but in Norfolk we don't tend to do those. They go to Norfolk County Council, but we do have a carer offer, and we're always seeking to improve that. So within the service I work in, carers can access up to 3 sessions with a psychologist or therapist if they have their own needs and those need addressing. We also have, Catherine runs a Carers in Recovery course at the Recovery College that people can attend, and we have carers leads that can meet to try and signpost towards other sources of support. So we can't meet all the support needs of the carer if they've got their own mental health issues. Our local wellbeing service will see any carer that we feel is really struggling, and it is impacting on their own mental health as well. So it's not completely covered, but we do try and make there to be many routes in for the carer to get support, basically.
Fantastic. I have 2 hands up, so could I start with Sangeeta, if she's still around?
Hi.
Hi,
Hello.
Sangeeta.
Hi. I've been trying to engage with my local mental hospital, and I'm, of course, speaking to the medical director, who is a psychiatrist. And I just find, like, don't know, this language would not be understood. You know, this is a different language that you and I speak. So I'm interested to know what is, where do your psychiatrists stand on this?
Well, one of our main sponsors is our medical director, actually, and he's the one that got us the money to run this project, so he's right behind it. So I can't speak for psychiatrists in general, but the ones we've spoken to have been very welcoming, actually, of the approach. So I think it may vary a lot from person to person, rather than being able to make any generalizations about psychiatrists in general. But without the backing of Liz Howlett, who's in this meeting, who got some money to start the project on, who's our suicide prevention lead, our nursing director and our medical director, we wouldn't be in a position where we could roll this out. So I think those people will be there within any organisation.
It's trying to find them.
Yeah, yeah, it is. Yeah, to support it.
Yeah, fantastic. And Claire, if you're there.
Yeah, I'm here. Okay, so I'm from Belfast in Northern Ireland. I'm the chairperson of the Family Voices Forum, and we're an organisation of families who've been bereaved by suicide. So we we work with the statutory organisations around change.
Yeah.
Training that you do, have a couple of questions. The training, is it mandatory or is it optional, and what's the uptake? When you first floated the idea, what was the response from the directors and the staff within the statutory service? Because we find that sometimes they're very risk averse and there's a lot of fear there. We have talked a lot about triangle of care, and where some people have kind of been very on board with it and would like to take it forward, others are a little bit more hesitant. And can we have, would you share some of the sort of the beginnings of how you took forward work and put it into place, so that we might be able to look at it and take it forward in Northern Ireland?
Okay. Yeah, I think that where there's strong feelings of loss and anger, actually, we went into Great Yarmouth at Waveney because there had been a lot of patient suicides there, and our trust knew we had to do better. So there was already an appetite to do better, and I think where there's an appetite to do better, you push against the open door where there's an appetite to do better. So I don't know. It's about, again, I think it's about, there will be those people in those local organisations. You've just got to find your way to them. Yeah. So
I mean, I would say the team that I worked in has even before the Care Act had always worked really closely with families of people in their services, the community team, and we're also a team which really champions recovery. And the foundations of recovery. So I had no blocks in regards to doing that and working in a systemic way, and I had been working in a systemic way with my team as a carers lead, and not being clinical. I was accepted, and they could see how change had happened and how we had moved forward. So we used that as a platform as well. So
yeah, and I think getting that local sign up is important. We had data, and that really convinced people. So there's the national data, like I said, but we had our local data as well. And actually, when you present that to people, and it's actual lives lost that could possibly have been saved if we'd been a bit more effective, but in involving our carers, people are fairly convinced by that. So mostly we felt we were pushing against open doors, really. I don't know when it's a different experience. Maybe we were lucky because our organisation was at that point where they really wanted to change as well, and that's been demonstrated in all kinds of ways. So we've now got a family liaison officer, and things like that. So I think the organisation was at that point of change as well.
I'm mindful of the time, so what I'd like to suggest is I have, so other than somebody asking whether or not there are any jobs going, which is a great question, I have one more question from somebody asking about the whether or not there are national collaborations and if one could be set up. And I think that's probably something to answer with the NSPA. So I will take that back to Penny Foston. What I'd like to suggest is, if we bring the session to a close, but if you don't mind just staying on for another couple of minutes, and anyone else that wants to chat to you and ask questions can just stay, is that all right?
Yeah, that's fine. Yeah,
so
perfect.
So thank you very much for attending, everyone, and I hope you enjoy your lunch, and please come back for the afternoon. And if you'd like to stay and just chat for a bit longer, then please feel free, and I'll keep sort of chairing until just gone 20 past.
Okay. Thanks, Sarah.
Thank you. Yeah, I think a carers, a sort of subgroup of the NSPA that was working on involving carers more closely would be really good.
Yeah.
And I think there would be a national interest. It would put us all in touch with each other as well, which would be great.
It would, and certainly from the bereavement, obviously I'm going to talk from the SASP side of it, the Support After Suicide Partnership side. We last year began to reach out to family liaison officers because I couldn't believe there isn't a national network, informal national network for supporting each other. And the response was enormous. And actually we had to put a stop in it because I didn't have capacity. But I'm delighted to say we've just appointed an engagements manager, and that's something we'll start to do in Q1, 2 of this year. So I wonder if it's worth, and that's why I said I'd take it back to Penny, because it's something where I think we could really use the working together and set up a network.
Yeah.
Okay, we have other questions. I will keep asking. Lots of people saying thank you, and it's amazing and inspiring. So
yeah, thank you.
Yeah,
we're really enjoying the work. So yeah.
So Claire from Northern Ireland, please do contact us directly, and we're very happy to have a conversation.
I'm not sure if Naomi Sutcliffe is still with us, but she asked, how do you manage care needs when there's a relationship breakdown within those around the person who needs caring? And you know, there's something that she finds very complex, and can you help that with training?
I think, as Deirdre said, you just have to try and be as open and honest, and, you know, take away the barriers, and, you know, we're here, you know, be there to listen. We can't solve everything, but we need to have an open door, and, you know, conflict can be overcome, and it's not always easy.
And conflict can lead to greater understanding as well of what the obstacles are and what the difficulties are. So just being really interested, if a carer's feeling really alienated, it's actually just showing that you're interested and curious about that, and you want to know, you know, where we've got it wrong, you know, what are we doing, how can we involve them more fully. So we, in the safety planning clinic, we haven't, mostly it's brought people together. It hasn't increased fracture in those relationships. It's brought people more together. I can think of one occasion where it clarified differences between the carer and the service user, but that was actually useful as well. And the service user was then able to have a conversation with their carer about what they wanted going forward. So it didn't, but the conflict was already there, but they actually clarified what the next step was. So mostly it makes the triangle stronger. We haven't had any sort of catastrophic effects on our relationships with carers by virtue of going in and being a bit challenging of what the current approach is and things as well. It's actually, people were just really grateful to be involved and listened to, because that's what they felt they weren't being, what they felt wasn't happening prior to the intervention. So
I'd like to ask Andy Willis if he's like to.
Yeah, apologise, I had a bit of trouble getting into the room, so I may ask a question that's been covered earlier. In terms of obviously dealing with the really sort of chronic suicidality in extreme cases, with the level and depth of the triangle of care and the support that you give, wider in the trust with respect to safety planning, if not at that level, is there a similar engagement or ambition to have the carers in and sharing, for want of a better word, if it's appropriate, a lower level safety plan, very important at any level, but is it wider than this particular group, because it's such it's an important principle?
Andy, I can hopefully answer that question, because alongside this project, we are now implementing, I don't know if anybody's uses Dialogue Plus, but it's a solution focused intervention for staff and service users, and alongside that, and carers, and alongside that, we are delivering safety planning training for every single member of staff in every single single service line, which we are very much focusing on carer engagement and the importance of that, and how it can support safety plans and the safety and the support around that person. So that is happening at this moment in time in our transformation plan within Norfolk and Suffolk Mental Health Trust. So that is happening, and then this is a bolt-on to that from higher risk, more suicidal service users.
Somebody else went. The only other question I've got is particularly the importance of, if you had a service user or a GP or anyone that was going really strict on the confidentiality, or if there's a breakdown, I know there's common sense confidentiality. Yeah. How do you deal with a situation where someone is really vulnerable, and it may be the service user themselves not engaging or going with the strict confidentiality, and you know it's in their interest to try and, I mean, I'm almost sort of waffling too much.
I think that's about understanding the dynamics of the situation, and you know, somebody in my role as a carers lead, not working directly as a care co can come into that situation and really have those focused understanding conversations that give clear understanding, that then is shared at team meetings, shared at professional meetings, shared at MDT meetings, so then you have a whole picture. So yes, carers, you know, confidentiality may say that we cannot share information, but what we have to do is listen. We have a duty of care to listen to that family member, to listen to that carer, and that is what we are trying to do and strive for.
So part of our general training that we did started off with understanding the limits of confidentiality, but actually that does mean we can listen, we can document information. It also means that in situations of imminent risk to that service user, we can disclose information. So just getting everybody to understand that even though the service user had said you can't share information, in certain situations you can, but also revisiting that conversation. If you have a service user who's adamant that they don't want information shared with their carer, that you keep revisiting that conversation with them, and you keep selling them the benefits of involving their carer, saying, I understand there's a lot of conflict, you know, involving them might be a way of solving that conflict. That might be something we can help you with. So just keeping it on the table that people are generally safer when they have people in their support network. They just generally are. We know that loneliness and isolation and fractured relationships is likely to increase someone's risk. So just keeping that on the table rather than just saying, oh, we've done the form and they've said no, you know, actually let's revisit that. Is it now a time that we should be involving your carer? I can see it's impacting heavily on your carer as well. Do you think we should really be involving them as well? You know, so just keeping that conversation as an open one, not taking the no as a forever no, because it may not be.
And also informing service users that while we will not disclose, we will speak to that person.
So, I mean, your model is actually spreading common sense confidentiality as a good practice throughout the trust as well. I'm not saying it wasn't there before, but
I love that. I feel like we need to tag that common sense as best practice. I think, Andy, you might have just coined a phrase there that we should be using in the field.
I don't think it's mine. I think it's something called common sense confidentiality.
Yeah.
And the very last thing, I do apologise. For those that are perhaps haven't had suicidality, with the risk between the link between self-harm,
yes,
and is that a safety plan approach similarly to be explored? Yes. Yeah. Thank you. Thanks for that. I'll have to go now. I appreciate your time. Thank you.
Thank you.
Thank you.
Thank you for all your positive comments.
Thank you.
Thank you.
Okay,
I'm going to bring the session to a close, but yeah, please, everybody, the emails are in the chat and this will be around afterwards. So see you this afternoon, and thank you so much to our speakers.
Thank you guys.
Bye-bye.
Stay safe. Bye.